Good morning and welcome to today's Region 7 Disaster Health Response Ecosystem webinar. Today we're discussing kids and COVID-19 returning to school amidst a pandemic. We have three presenters today, Dr. Wellington, Dr. Sato, and Dr. Broadhurst. Objectives here are seen on the screen for today's webinar. Today's webinar is accredited for 1 hour for physicians, nurses, and EMS providers. Disclosure declaration. And then our following faculty today, Dr. Sato does have a disclosure, and then for our planning committee, Dr. Lawler. If you have any questions throughout today's presentation, please go ahead and place those in the chat, and we'll monitor the chat and come back to questions at the end of the presentation. And then here's the information to access your CME certificate. You'll go to unmc.edu/CCE, enter today's activity code, and this will also be provided via email and at the end of today's presentation. With that, I'll go ahead and introduce our speakers. Dr. Wellington is a clinical professor of pediatric infectious disease and associate hospital epidemiologist at the University of Iowa. She's board certified in pediatric infectious disease and general pediatrics. We have Dr. Sato, who's an assistant professor in the Department of Pediatrics, Division of Infectious Disease at the University of Nebraska Medical Center, and she also serves as the associate hospital epidemiologist for Children's Hospital Medical Center. We have Dr. Jana Broadhurst, who's an assistant professor in the Department of Pathology of Microbiology at the University of Nebraska Medical Center, and she's also the director of the Nebraska Biocontainment Unit Laboratory and Emerging Pathogens Laboratory. And with that, I'll go ahead and I will turn it over to Dr. Wellington.
Well, thank you, Lauren, and thanks to everybody for being on the webinar. The goal of my section is to sort of review where we are, or at least how we got here, with a few thoughts about kids and school and stuff along the way. So general epidemiology is going to be pretty simple. I like to start talks with this slide. It gives me a bit of perspective that humankind has had pandemics before. This is a visual capitalist, makes some fabulous images, but that over time, there have been all these pandemics, and the size of these fur balls is proportional to the number of people who have died from the pandemic. And of course, here we are, and we're in dashed lines because we're ongoing. And when I started talking about this, the ball was about this big, and obviously now it's much larger. And I think that gets to the crux of the real issue, because a lot of people now are starting to say, are we at a point where COVID is endemic? Should we stop all this quarantine and isolation and treat this sort of like we treat flu? And so I like to think about that this way. This is what's called a graph of excess mortality. So based on the time of year and the population and everything that's happened for the past 5 to 10 years, the grand epidemiologists of our country are able to predict the number of people that we would expect to die in any given week in this country. It's kind of morbid, but it's a very hard and fast number that there's not a whole lot of question about. Are people reporting or not reporting, right? This is the absolute end of the whole thing. And so if the same number of people die as you expect, it's a 0% change. If more people die than you expect, there's a positive percent change, and if less, vice versa. So you can see we were going along. It wasn't too bad of a year in 2020 for death until March 15th. And then we hit this massive inflection point as the pandemic hit. And for a long time, several years, actually, since then, you can see we've had a massive increase in the number of deaths in the United States, well over those that one would expect just from past history. However, right here in June this year, we hit the 0% point again. And now we're actually at or below our expected mortality. And you could say, okay, that's it. COVID is endemic. It's not creating an excess number of deaths compared to what we might otherwise expect. But here's the thing, if you look at this, COVID is actually starting to have a seasonality, maybe not its final seasonality, but we are definitely seeing the waves, which may be related to seasons, but for sure we get the early summer off. But then in late summer, well before school starts and well before you expect respiratory viruses, we keep having these peaks. Here's one here, and I don't know what will happen next here. But as we go back into respiratory virus season, we would expect these numbers to come up again. And so while we may be approaching endemicity, we are certainly by no means back into some sort of expected number of deaths in the US. And I don't want to sound like I take that lightly. I don't. Every one of these deaths is a real thing to people and their families, and it's awful. But this is my point here, which is that these excess deaths are what tells me COVID has not been endemic in the sense of we still have a lot of ground to cover before we have a population who's capable of regularly handling COVID. And while we are actually in a pretty decent place today, I seriously doubt that we won't, double negative. I'm pretty sure that we're going to go back up as we hit seasonal respiratory virus season again. And that you can almost see the beginnings of that. So this is the CDC graph. This is the number of cases per daily report, and then the red line is a 7-day average. And again, we had that dip at the end of respiratory virus season this year. But since sort of midsummer, we've hit sort of a sustained smolder. And these are the waves, not just from seasons, obviously, but from the variants. This is the Delta variant here, and the big Omicron peak here. And while the Omicron peak came back down, we're now dealing with subvariants of Omicron that are extremely contagious and also resistant to previous immunity. So we're in this like smolder phase right now, and it's not clear whether that's going to take off and go up again or not. And if and one of the things I want to point out as we look at these numbers is if I just take this section of the graph and enlarge it and stretch it out so I can fit it all in one slide. So that's the same thing that was in the orange section before. And the dates are stretched out because I needed to match it up. So I approximately matched the months here, not exactly, of course. But what this is a CDC study looking at people actually who had been on an online study for some other reason, and they got one of these sort of subsequent studies, like you fill out SurveyMonkey to say when you're going to be available for your meeting, right? And then SurveyMonkey pops up with, would you be willing to participate in another survey? And that's how the CDC has recruited people to do a lot of these survey data. And what they asked was simply, have you used an at-home COVID test in the past 30 days? And for symptomatic people in late January, early February, this is up to a quarter of symptomatic people were testing for COVID at home. And even for people with no symptoms, they may have been testing for visits to families, sporting events, worries, whatever. But 10 to 15% of people were actually testing even without symptoms. And the problem is that these people who have these positive home tests don't tend to report their cases. Some states have mechanisms for reporting. Some counties have mechanisms for reporting home tests, but not very many. And so these are the number of reported cases. And because of the sort of wide availability of home tests now, and people being willing to sort of either not test or test at home and not report, these numbers are probably now an underestimate of current caseload. And this brings us back to the variants, of course, which have made these waves. And we can't, of course, see the current wave as well as we would like to, but we do know that it's being driven by a variant BA.5. And BA.5 is a subvariant of the Omicron variant. And what this is each week, the CDC would put out they'll set out the numbers of all of the viruses that have been sequenced that they have the data for, what percentage were which variant. So this is time along the x-axis and the percent of each variant on the y-axis. And BA.2 is basically the regular variant of Omicron. And as you can see, since April, it has been being replaced by these other subvariants, either the subvariant of BA.2 or BA.5, another variant of Omicron. And that matters again because this BA.5 is highly resistant to previous immunity. So we're seeing a ton of people with reinfection. So even if we are hitting a point where there might be herd immunity or endemicity to some of the earlier variants, we're getting these new variants coming through. And hopefully evolution will continue and these new variants will be less severe in terms of the amount of disease they cause, but there's no guarantee that that will happen. And here's why I keep talking about BA.5. And this is a new preprint out from the New England Journal of Medicine looking at neutralizing antibody titer. So neutralizing antibody titer is the amount, the dilution you can make of a person's serum and still have them be able to block viral activity, neutralize the virus. Antibodies are not by any stretch of the imagination the only antiviral immunity we have, but it is the by far easiest one to study in large groups of people. So this is not to say that all immunity is what I'm about to present to you, but it's a marker for immunity and immune evasion. And so in these graphs, what you look at is along the x-axis are when they're testing neutralization, they're saying, does it neutralize this virus? And the virus is a strain, WA being the original strain, and BA1 and 2 being the early Omicron strains, and 2.12.1 and 0.4 or 0.5 being these later Omicron strains, with BA5 being the one that we're seeing now. And if you look at people who just were vaccinated and you take their serum before or after their booster vaccine and look at the titer to the original variant, which is the one that's in the vaccine, of course, there is a lot of antibody produced, but to these Omicron variants, there is less, substantially less. And then when you boost them, you get a big rise here. And this is one of the big reasons for starting to have the boosters, because this is a very important component of immunity. But what you can see is if you look at these comparator numbers, BA5, the antibodies that were produced to BA5 with our traditional vaccine, which is to the original version, are 21-fold lower titer than to the original version, and even say 3-fold lower than to other Omicron strains. And some people say, well, I don't care about that. I had it, so I'm immune. I don't need to worry about vaccination. And this group of people are people who were infected with the BA1 or BA2, so they had Omicron, right? And most of these people actually were vaccinated as well. So they were vaccinated and they had Omicron. And then you look at their antibody titers. They're higher, of course, because they had Omicron, so they were recently infected. But there's still this huge fall. So a 19-fold fall in antibody titer from the original Omicron strain to BA5. So if you're anything like me, you know a ton of people who are complaining about how much they're unhappy with the fact that they got COVID another time. And that's because of this lack of immunity. So that's sort of where we are now in terms of general epidemiology, but this is a discussion about children. So some more information about that. And the first piece of information is, as is usual with children, it's very difficult to get good data. The American Academy of Pediatrics compiles reports from each state, and it is really sort of the best source we have from the US on data for kids. It's similar to the data that CDC gets. I don't want to diss the CDC, but the AAP obviously is very targeted at finding the data for kids. And this slide, you don't have to see all the details, but basically the left one is the state reporting the age of the person who has COVID at all? So they have to report the number of cases they're seeing in any given day. And do they, with that report of number of cases, report the age of the person or not? And there are some states that actually never did. And there are many now that are stopping. And of those, so you can see the blue ones are the ones who are reporting the age currently. And even if you do report the age as a state, what you count as a child is completely variable as well. So remember that as I show you this data, it's our best estimate, but we don't have any national or regional rules about how this data is reported, which is pretty amazing. So here's the data that they've put together. Again, case counts over time, and this starts back in April of 2020, so the whole pandemic. Here's the first wave, and then Delta, and then Omicron again. And in this case, the light blue line are the adult cases, and the dark blue line are the child cases. And near the beginning, there were very few cases reported in children for several reasons. Number one, remember back when we had almost no tests? We tested almost no children because they were not at high risk. And then also with the lockdown, people went back to bars before they went back to school. It was just one of those weird political moments where people were going out to restaurants and stuff like that and still saying, oh no, we're doing teleschool for my kids because that's not safe. And so there was in here, through here even, quite a lot of adult infection, whereas the kids were being sheltered, which was interesting because kids usually do substantially better when they have COVID than adults do. But that's society for you. But you can see as the Delta and the Omicron wave started to come around, we started to really pick up in the number of cases who are children. And that for sure in recent history has been consistent. And more recently, it's hard to know again with the child cases and that sort of thing, but we still are having a large number, a percent of the cases are in children. So when we were first reporting, it was 2.5%, and now we're up to 13.7%. And that seems to be fairly consistent through these last few waves. And so just before we transition into talking about vaccine and stuff like that, the other question I get all the time is, if kids do so well, because even though they have those many cases, really there have been very, very few deaths from COVID in children. If kids do so well, why would we need to vaccinate children or even worry about COVID transmission in schools or other places where kids are transmitting COVID? And I just want to point out that there are lots of reasons to worry. The first is ED visits. That's a pretty straightforward worry. And this is a graph from the CDC again about the number of the percent of the ED visits that the reporting period that were for patients who were diagnosed with COVID-19. And the different colors are ages, and these are the age things. And you don't have to see individual lines here. I'm going to blow up the relevant part for you later. But these like sort of funky gold gray lines down here, that's the kids. And so and they go up when the case counts go up. But again, they tend to be doing quite well with COVID. So, but if I bring up this area for you so we can all see it better. Oops, somehow I've lost my slide, sorry. What I would point out to you here is this kids line, this gray dotted line, it goes like this. I'll just trace it out right here. To the point where right now, the largest percentage of ED visits for patients diagnosed with COVID are happening in children. So we don't really know what's going on here, but it is quite concerning. And I have my personal data that I can tell you about, which is absolutely not database, it's completely anecdotal. But we have seen over the last year and a half, a remarkable increase in severe invasive bacterial infections. Now, all major viruses, especially the primary infection with the virus, predispose the host to bacterial infections. There are changes in the immune system, changes in the microbiome, you name it. So all viruses predispose to post-viral bacterial infections. But we have seen an outrageous number of patients with brain abscesses, bacteremia, endocarditis, and other staph infections. And in fact, there have been so many brain abscesses, not just here, but at many centers through the country, that the CDC has actually issued a request for cases and is currently gathering data on brain abscesses in pediatric patients right now. So we'll see as they manage to go through that, they'll be able to help us figure out, is this one of those random clusters that looks like a pattern because that's what our brains look for, or is this actually an increase? So again, this is not database, it's a personal observation, but do with that what you will. But I would like to point out that we've had several of these patients who came in with severe staph bacteremia or staph endocarditis, who were initially diagnosed with MIS-C because they had post-COVID, fever, rash, low blood pressure, and high inflammatory markers. And these patients who were actually in Staph aureus sepsis were treated with immunosuppressive agents because people thought they had MIS-C. And so here's my personal plea, which is to remind everybody that not all post-COVID patients who have inflammation actually have MIS-C. This is the number of the kids who are getting MIS-C. And remember that MIS-C lags behind COVID diagnosis by 4 to 6 weeks. So the COVID curves, the same as you've seen before here, are these black lines, and the MIS-C curves in the blue ones. And look, there was a big curve after Delta. And this is, again, as these sort of home tests started to come up. So I don't know if that's because Delta caused a lot more MIS-C, or if we were just missing the original cases in the overall case counts. There seemed to be less associated with the early Omicron wave. And currently, it's too soon to say for BA.5. I've put this gray bar here because that's that lag time. We know how many cases of COVID have happened recently, but we haven't had enough time after those cases to find out how many kids are having MIS-C. And I don't mean to discount the severity of MIS-C when I was talking about the bacterial infections. It's just that all of these things are happening to these kids all at the same time, and we need to be careful about sorting them out. Oh, sorry, this apparently my slides, I messed up the order. This is that ED visit. You can see this is the kids line that's coming up for ED visits right now. And then this is the other data about post-COVID bacterial infections. This is a new Nature Scientific Reports preprint. And what they looked at is they compared bacterial infection after flu versus after COVID. And overall, the number of infections was not different. Okay, I want to emphasize, they didn't see a difference in the number of infections. When they broke them down into gram-positive or gram-negative infections, and whether they occurred early, which is within 48 hours of admission, or late, which was 48 hours to 2 weeks after admission, they started to see a significant difference, which is that a dramatic number of patients who were post-COVID had these later infections compared to patients with flu who were more likely to have the earlier infections. So for example, 24 to 14 for early gram-positive versus 10 to 28% for the late gram-positives. And the same thing happens with the gram-negatives, whereas flu is 41% of the patients that they were looking at with infections had the early gram-negatives versus 25% of the COVID patients and then that flips when you go to the late data. The totals again are not significant, right? So people are still it's a post-viral thing. But what seems to be happening is, and this is, they only counted if it was within 2 weeks, and we're seeing infections 4, 6, 8 weeks out. This is something that's going to be gathered over the next period of time, but a better understanding of the sort of post-COVID impact on the infectious disease situation in children. And of course, I had to put together a question slide because I'm so used to it, and we'll be taking questions at the end. But this is my big question that I think about a lot lately, which is I wish people would have more of this attitude of, I'm only going to really be intimate with you if you've been vaccinated. So with that, I think we'll turn this over. I think, right? Yes, excellent. So thank you very much for listening, and I'll be back for the questions.
Hey, so hi, I'm Dr. Alice Otto. I'm a hospital epidemiologist for children's in Omaha. I'm just looking for how to advance the slides. Let's see. So my role here is to discuss vaccination. Does that work? Okay, and those are my disclosures that were already shared. So the too long didn't read or possibly didn't listen is that COVID, MISC, and then also long COVID, which Dr. Wellington didn't mention, but does happen in children and can cause school absence and family disruptions, are serious disorders in children. This is a summary slide that you can see that is supported by many professional societies, including SHEA and PIDS, which is the Pediatric Infectious Disease Society, with additional information. But that children have been infected, children get sick, children come to the ER, children get hospitalized, and very rarely children die, but it has been in the top 10 and even really recently in the top 5 causes of death in children. So we believe in preventing those disorders. So just to remind you a little bit of a difference between the virus and the mRNA vaccines. I'm focusing on mRNA because that's what's approved for children. The virus itself has multiple components. It actually has more different proteins than are shown in this, but the vaccine only contains the one for the spike protein that is one of the surface proteins on the of the virion, and that gets taken up into the cell, and the mRNA is released into the cytoplasm where it's translated on the ribosome to create the protein. And this is one of my favorite analogies for how the vaccine works. So normally we think about that your genes are a cookbook and they make instructions. So it makes a photocopy and sends it out to the kitchen to tell the chef how to make the cake. And what we are doing instead with this vaccine is sneaking in with a recipe. So it's not going anywhere near the cookbook. It's not changing the genetic instructions. It's just giving the chef an idea to make this spike protein. And that can be taken, can be expressed on the surface because it's made in the cell. It can be presented in class 1 and help induce T cells. It can be expressed and released and taken up by other antigen presenting cells and help make antibody responses as well. So it's not live, it's not infectious. You can't pass it on to someone else, and it has no impact on your genome. And these are the original vaccine trial curves because one company, yeah, I guess they swapped the colors, but the top line for both are people who received placebo, and the lower line of not accumulating new cases after about that first week or so are people who received the vaccine. And these studies involved around 35,000 or so, 40,000 people in each study, in each trial. And the vaccine efficacies against the original virus that was circulating was in the 95% range. So these were a wonderful success, and we were very happy to roll them out for adults. This is one of my favorite cartoons that came out around that time, saying really, you don't need to know a whole lot to be able to see that that's really effective. So this was data that came out. So that the Pfizer study went down to age 16. So the next age group that data was available for were 12 to 15-year-olds. And in the 12 to 15-year-olds, I don't have a curve because there weren't any infections with 100% effective within the study. And so that also was a fabulous success there. And what we know is that these vaccines in practice worked really well. So healthcare workers showed reduced infection. It decreased hospitalizations and deaths in older people. And here's the healthcare worker data. So in people who were being screened on a regular basis, they weren't seeing infections even early on. So we'll come back to that idea. And here's going through August of last year. So you can see that there was a big difference in hospitalization rates between vaccinated and unvaccinated, and that carried through for deaths as well. And so you can see at that peak there was actually a much higher difference than the 10 times that's cited at this particular slide. So again, this is from a year ago. And with the onset of the Delta variant, you could see that really being vaccinated is super important. And same for teenagers. So we were vaccinating 12 to 18-year-olds. We obviously had fewer deaths in children, and I am not complaining, but it also decreased the need for hospitalization. If they were hospitalized, they didn't end up in the ICU. So they did really, really well with this vaccine. And that's through September. And for MISC, that post-infectious complication that Dr. Wellington discussed, vaccination really made that almost go away, right? And that's true. I've analyzed the data of the over 100 children that we've had here. And really very few were even partially vaccinated, much less vaccinated. And then you can see we then had data presented for vaccinations for ages 5 to 11, and that was tested a little bit later on, so seeing slightly different variants, but that still showed an excellent vaccine efficacy of about 91%. So this is that same sort of case graph that she showed you, but I've kind of marked where the different strains were. So the original Wuhan/Washington State strain kind of came into our first winter wave, and then Alpha kind of had that little hump that happened. And then when we came into last summer, we were really seeing Delta and before Omicron hit. And to remind you, similar to what she told you, this is looking at people who had received the Pfizer vaccine and testing that same blood against, in the lab, can it neutralize viruses of different types? So you can see the same strain that it's based on is that gray on the left, and it worked well for that, for Alpha, for Beta, for Gamma. Beta we didn't, and Gamma we didn't have as much. Delta, Lambda, which we actually only had a couple cases of, and Mu. But you can see when we get to Omicron, it does not work as well. The same thing she showed you before, right? And but the effectiveness, if you look after 2 doses, and this happens to be Moderna data, but they're very similar, that it works pretty well against Delta with 2 doses or 3 doses, but you really get a much better response against Omicron, and this is against BA1 really, or the January version of Omicron, where you see that additional dose, that booster, is really important. And as a subunit type vaccine, I will say we frequently need more than those 2 doses. So this is based on tetanus data, but I'm showing you this because I think it's really helpful for people who don't think about vaccines very often. When we give that first shot, we start to get a little bit of expression. We get our T cells interested, we get our B cells interested, and we start to produce, this is looking at antibody levels. And then when we give that second shot, it really amplifies that response, and you get a surge in the amount of antibody is made. But waiting in that level of antibody is actually pretty typical for vaccines. The question is, does it stay at a baseline that's high enough to protect us against disease? And in the case of tetanus, we know that 2 isn't enough. And so we get that third one. And everyone's very comfortable with the idea of getting repeat boosters of tetanus. So we're used to this idea. We just kind of forget about it. That over time, right after you get that initial series, and that's often 3 or 4 doses for this sort of vaccine, that after that, we might not need to boost as often. But it does help us maintain a better immune response and a better level of antibody. And so if you look at the gray part of this, what they did was they looked at a third dose or that first booster, and what kind of antibody levels do you get to the original virus in gray, right? And you can see that it made, yeah, you know, after dose 2, it wasn't, it goes up and then it goes up again. But if you look at the blue for the Omicron, the BA1 that we saw in January, dose 2 didn't do it, but dose 3 really made a big difference. So getting that booster is really important. And if you haven't had it, you really should consider getting it. It's really important to really lock in that immunity. And it's now recommended for boosters down to age 5. This is similar to what Dr. Wellington showed you before, where if we look at different types, we see this booster effect, and we see it against different spike types or variants. So even though we're using the same original strain as that vaccine, and we haven't changed it as of yet, it still induces immunity against these other strains, but having that additional dose is really important. And so this shows waning over time, but waning is slower after your third dose and your second dose. So if you're getting the idea that I really believe in getting that third dose, you are correct. So I built the slide here to try and match. And so I built the thing down at the bottom, so I don't know why the dark purple and the light purple switched, but you can see just based on color that we're seeing replacements. So that dark purple is BA1, right? Or the light purple is BA1, and then we get BA2, and then the BA3 didn't succeed. So we got BA4, BA5 now. So we have seen a change in that, and that reinfection risk is real with BA4 and BA5. So unfortunately, everything's called Omicron. And again, like Dr. Wellington said, we think, oh, well, I had Omicron already. But unfortunately, it's not true because they're not the same and they're not immunologically the same. And you can see on this map that region 7, just like every other region, is really heavily dominated by BA5 right now, that dark teal color. So very exciting for us in pediatrics and for parents of small children. An EUA or emergency use authorization was granted for both the Moderna 2-dose series and for the Pfizer 3-dose series for children under age 5. And a third dose for immunocompromised. Now, I want to point out that the way we do test studies for approval in children, because there were such low rates even of hospitalization, but ICU admission and death, what they used is something called immunobridging. So they picked an age of grownups that made the best antibody responses in the adult studies. Slightly different age groups between the two vaccines, but you get the idea. So here they compared it to 18 to 25-year-olds who had the most robust responses when they measured neutralizing antibody in the adult trials. And they said, do children make as good an antibody response? Because our guess would be that if you make as good an antibody response, you're also making T cells, and we would expect it to have a good efficacy as well. So that was the primary criteria that was used. Moderna got that with 2 doses. Pfizer did not see that at their second dose, which is why the study added on the third dose. But when they reached the third dose, you can see on this table comparing the did randomization, so they had more children getting the vaccine than getting placebo. And then they looked over time and they compared the immunobridging, and basically those numbers are 1 or higher. So they had at least as good an antibody response as the young adults. So you can see 16 to 25 or 18 to 25-year-olds, depending on the product. And to remind you that the way vaccine effectiveness is calculated is that you compare the rate in your vaccinated population and your unvaccinated population, right? So if you have a disease that very few people get, then you wouldn't expect very many cases regardless. So what you're looking for is how much difference do you see based on vaccination? whereas a disease that's very common, might expect a lot in both groups. So you compare those two groups. When the original studies were done, they were done with the more closely matching virus, because that's what it was based on. And also your unvaccinated population probably were also not immune at all, because they hadn't necessarily been exposed to infection. So the numbers might vary over time, but the real question is, what's it do in the real world? So it's going to depend on populations in the real world, includes people who weren't necessarily included, right? More immunocompromised people, people with transplants, whatever, who weren't included in the original study. So you might expect that number to be lower, because you have people who are not getting it on the right schedule, or their immune system isn't as good, or they have other issues that make them sicker, or they're exposed to different variants, or they might have some prior immunity because they've previously been infected. So those numbers move around compared to the trial. But looking at in the Omicron period, so really early BA1, BA2, when they looked across the antibody response, they saw the same response. This is just one of many figures that shows that they got the same amount of antibody response to these different vaccines, and that they worked well for equal ages. So when you look at hospitalizations across ages, this is for adults. That green line is not vaccinated, the blue line is vaccinated. So it makes a big difference for hospitalizations, and that holds up for the different ages. This is for teenagers, right? There's a little bit of a narrowing of the gap after that big Omicron surge in January, but you can see it's widening up again. So vaccination really still matters. And this is for the younger children. We still see a gap between those two populations. So we know it's safe in children. It's been used a lot. Over 600 million doses have been given worldwide, even as of June, and that we've seen very little in terms of concerning signals. So counseling, really, it's mostly local, what you expect from a vaccine: sore, a little bit red, maybe fever, but not high fever. In the youngest children, it was under 1% had a very high fever, but they might have a low grade fever. Irritability is more common as a concern in younger children. Febrile seizures are benign seizure events that happen in children associated with the onset of fever between 6 months and about 5 years of age. They don't have any long-term sequelae. Sometimes vaccines, but all sorts of other reasons that you get a fever can cause them in small children. So we do counsel that could happen, but we have not seen a big spike in these like had happened originally with the original pertussis vaccines. There is an at a glance that you can see, and it helps you walk through. I will point out that the booster dose originally was after 6 months, then 5 months, it's now 4 months. So this is very handy. I've cut it off. The adult part is at the bottom of these pages, and they also have it broken out by immunocompromised, where you can see that there is in some ages an additional dose for immune compromised patients. This is just to show you that vaccination is not uniform across the US nor across each state, and that we are not necessarily doing the greatest job with getting people boosted. And the US is that line at the bottom, lagging behind a lot of other countries in terms of getting boosters done. And then this is a national picture by race and ethnicity. We are not equally vaccinating. And by age, I have blown it up. And unfortunately, that little tiny line down at the bottom is children under age 5. We have only gotten about 3% vaccinated so far. So we really want to work on vaccine confidence in the parents of small children. It is still important. We are seeing, it's a top 5 cause of death. It's a top cause of hospitalizations. The disease can be a severe respiratory disease in these children. And this shows you that even across our individual states, we don't see vaccination as evenly distributed. And even this is Douglas County, which surrounds Omaha. You can see within a county, we have very different rates of vaccination. And so we really need to reach out to areas that are under vaccinated. So pediatricians are considered a key trusted source. or people's family practice doctor. Parents do want to hear both the pros and the cons of vaccination. They don't want you to just say, oh, it's beautiful and wonderful, and that using representative imagery is advised. And I've included a bunch of stuff in here, just additional resources the AAP has specifically for COVID. They have handouts that you can use in English and Spanish. They have an image gallery where you can get these lovely photos of children being vaccinated to use. Children's has a Fruitful campaign that has materials that you can put your own branding on, and we're very happy to share. We have Max the Vax NE for Nebraska, but we have materials and videos and such that we encourage people to look at. And then I wanted you to know about this national resource hosted by the University of Minnesota, but it includes many, many languages. And you can see that there are materials in multiple different languages, and you're encouraged to use this as much as you like. And they have all sorts of different ways of messaging and reaching people. Thank you.
All right, great. So my name is Yana Broadhurst, and I'm going to take the last segment of the webinar. I will endeavor to wrap up to leave 10 minutes at the end for questions. So I'll move fairly quickly. And my objectives for this session are to focus on the role of testing to reduce risk and increase safety in the K through 12 school setting. So I'm going to talk a bit about the testing strategies that can be applied in the K through 12 school setting, but I'm going to focus on highlighting resources that have emerged that provide guidance and implementation support for districts or states that are interested in implementing testing programs. I've been really struck by the quality and depth of resources that have emerged from across federal agencies, as well as foundations to support schools in this process, which can be quite logistically intimidating, but ultimately, again, a lot of support is now available. If we have time, I did highlight a few studies that demonstrate there's not a one-size-fits-all for successful school testing programs. I focused on studies that have been performed in U.S. school systems because there's certainly considerations that are unique to our settings here. Those will be available, of course, in the slides if we don't have time to discuss them during the talk. Okay. I am trying to advance my slide. But Lauren, I'll need help. Thank you. So this is an overview of the testing approaches that can be taken when considering how to apply testing to the school setting. A lot of the resources that I'm going to highlight have fantastic descriptions of these testing approaches and the various considerations, some of which I've outlined here at the bottom of the slide. But to say them quickly, we think about testing strategies in three domains. The first being diagnostic testing, which is applied to individuals, an individual who either has symptoms or has a known exposure to a COVID-19 case. And so the goal of this individual diagnostic testing is to identify cases ideally early and to link those individuals to appropriate services. There are examples of how this has been implemented in the school setting through simply linkage to and access to diagnostic tests that may occur at school, at home, or otherwise through linkage to community-based testing resources. There's been really excellent locally here use of phone apps to guide individuals to use of testing. And I'll highlight at the end a few studies that have looked at an approach called test to stay, which the goal of which is to utilize testing for individuals who have been exposed, but who are not displaying symptoms, to potentially shorten or eliminate a quarantine period and loss of time with in-person learning. The second bucket here is screening testing. This is where groups who are considered to be at higher risk, but who are asymptomatic, undergo regular testing. So regular screening testing. So these groups might be those who are engaged in high risk activities. Certain sports activities have been particularly well recognized here, but it might mean an entire school or school district in the context of reaching certain thresholds in community case pressure. And finally, there's surveillance testing. And this is where there is, again, regular routine testing, but of a representative sample of the population. So an example might be weekly testing of randomly selected 10% of staff and students. But surveillance testing can also occur with environmental monitoring, like wastewater testing, which has really taken a foothold in programs across our region as well as nationally. And the goal with surveillance testing is not to identify individuals with infection, but rather to monitor trends in case rates within that population that may trigger the escalation of other risk mitigation measures. That could be an escalation in moving towards screening testing, but that can also mean bumping up other tools that we have, of course, like masking and social distancing, et cetera. So within these types of testing programs, there are a lot of considerations, and this has simplified somewhat, but there's really a diverse toolkit for designing and implementing testing programs. There are different testing methods, as we're all very familiar now with antigen or PCR-based methods. In the school setting, both nasal swab as well as saliva have borne out to be very effective specimen types with different advantages. Pooling is something that can be carried out with either specimen type, and I'll highlight a couple of studies that have demonstrated that. Who to test, how often, and where. We now have options with tests being authorized for being performed at school. These can be self-collected, they can be performed at home, and as well as other settings. But this has really expanded, again, the available options. Depending on the type of testing program, it may be very important to partner with a testing laboratory, of course, for laboratory-based testing like PCR. And so understanding local and regional resources for commercial, academic, or public health laboratories who may partner in these types of programs is important. And of course, there's the ever important question of how to fund these programs. So these are a lot of questions. And again, what I'm going to highlight today are the resources that are available now to help schools and communities and states navigate what may work well and have impact in their setting. So this, I'll spend a few minutes now. This is not going to be a data heavy portion here, but rather, again, just pointing you to the resources available. Next slide, please. If we can move back. Okay, so resources for K through 12 COVID-19 testing. So guidance and implementation support. I'm going to highlight here resources that have been made available through the National Institutes of Health, through the Centers for Disease Control and Prevention, as well as two resource sets from the Shaw Family Foundation and the Rockefeller Foundation. Next slide. The NIH has funded a collaborative effort called the APC Science Collaborative. This has supported both implementation studies of COVID-19 school testing, but also the generation of a very nice set of resources and publications that are openly available. So I put the website up here, abcsciencecollaborative.org. You can see that they've organized their COVID-19 testing tool based on the goal of the testing program. And they then link down to a nice set of considerations for how to make achieve each of these types of goals through different testing models and utilization of different methodologies. So there's a really nice, accessible list of definitions and descriptions of these different components. Next slide. So the NIH has also provided guidance and resources coming out of an initiative called RADx. This is the Rapid Acceleration for Diagnostics. The UP stands for Underserved Population. So there's been a big focus in funding projects to better understand how to increase access, utilization, and effectiveness of testing for underserved populations. And within the RADx UP initiative, there's been a targeted set of projects focused on testing used to increase the safety of in-person learning. So again, that may mean in school testing, but that may also mean increasing access to testing for families that can be used to improve school attendance and safety in schools. So what I've shown here is just a snapshot of their resource dashboard. I found this again to be a very nice and accessible resource, particularly for those who are interested in evidence of implementation and publications that have come out of this initiative. You can see that there are drop-down menus there for audience, topic areas, and resource type. So that can be, again, the primary literature, or it can be flyers and ways to communicate with diverse communities about the value of testing. I will note that we here have a project that is funded by the RADx UP initiative, working with the Nebraska Migrant Education Program to utilize a screening app in combination with home-based testing to improve school attendance and safety for migrant children and migrant families served by that program. Next slide, please. This is a publication dashboard, again, just an easy to access literature database, a bit more focused and easier to navigate than our conventional literature databases. And I just wanted to highlight this. You can actually hone in on the Midwest region and understand what projects have taken place in our in Region 7 and a bit more broadly in the Midwest. For that target audience. Next slide. Moving now to the CDC, and again, I will have to fly through this. The CDC, I think, has really built out a robust set of guidance and testing implementation toolkit resources. So I'm going to have to just move through this quickly. I highlighted, I really just wanted to point you to where the menus of resources are within the CDC website. And the arrows that I indicated here are two resources, again, from the Shaw Family Foundation and the Rockefeller Foundation, that dive quite deep into example programs and very explicit documents and resources that schools can use to get a testing program off the ground. Next slide. The CDC also provides an overview of federal funding programs, some of which are extending into the next school year and some of which are not. So this really requires a bit of a deeper dive in terms of resources that will be available moving forward. But there has been over the past couple of years a tremendous a set of funding initiatives to get these programs off the ground. But moving forward, that is a bit less certain. This is a snapshot from the Rockefeller Foundation testing playbook. Again, just wanted to provide the website here and a quick look at how they lay out their playbook and resources, all the way from first considerations of what's the right type of testing program, all the way to monitoring the effectiveness of that program. Slide. And for the sake of time, we'll just leave this to the slides available when this is sent out. But there's actually a slide before this where I highlighted a few programs that have taken a screening and surveillance approach using either rapid antigen tests or saliva tests, both school-based, laboratory-based. So providing a representation of the different approaches there, and also highlighting a program that we carried out locally with Omaha Public Schools here, and then a couple of publications that have come out trying to again represent diverse implementation settings here for utilization of testing to improve school attendance and reduce quarantine periods through the test to stay strategy, which is something that's really taken hold. And so again, these are publications I recommend as high quality and representative of successful programs. Next slide. And with that, I will go ahead and make sure we have at least a couple of minutes for questions. Thank you.
Thank you, Yana. So first question we're going to tackle is from Melissa Prenick. She attended a webinar last week, and there was mention that possibly doing antigen testing in schools beginning this fall. What are your thoughts, and how, as school nurses, do we cover ourselves /RN licenses to administer these tests, and will they be provided to the schools?
Apologies. That's a great question. So again, within these resources highlighted here, those questions are explicitly addressed. Locally, antigen tests here in our region are available to schools through state public health departments, and can be requested for use in school or again for distribution for home use. And there's excellent guidance on how schools can obtain a CLIA certificate of waiver to perform those tests in school. But that's the key language to look for.
Dr. Sauter, you had here's another question from Dr. Broadhurst. It doesn't seem like the saliva test is being used very much. If it is as accurate as it sounds like and so much less invasive than the other schools, do you have any suggestions on how we can get these used more?
Yes, so the saliva testing we are actually using quite extensively here locally in Omaha, not in K through 12 schools, but we are actually partnered with the Oglala Sioux tribe, and Pine Ridge is a nice example of utilization of that testing in the school setting. So it is being used, but the saliva testing does require laboratory-based PCR testing, and so that does require partnership with laboratories. There's a national initiative called Saliva Direct that I didn't have time to talk about today, but who has that is led out of Yale, and it's been a phenomenal example of how to pair local laboratories with schools to implement saliva testing. And so I would point to that resource for more information as well.
All right, we have I think time for one last question. What is the guidelines for kids on quarantine for exposure or positive results?
Actually, I think that would be better sent out as a follow-up link along with the one that I accidentally hit as answer live, which is the at a glance reference. I would like to put in a plug, if it's okay with everyone else, for the question about what is happening with boosters for people under 50 and not immunocompromised. And the answer is nobody exactly knows. The FDA had requested that the fall booster be prepared with a BA4, BA5 type component in it. What they showed during the meeting when they looked at data was that having a combination actually was better than an individual one. So they are looking at a mixed product. So it's possible they will announce that that's what they're doing. And so there's two parts to that. If I was like a teacher and about to walk into a crowded classroom and I had not gotten a booster, I would personally go get a booster today because my risk of getting infected today is high, and getting that booster today is going to protect me. And, you know, I don't know if they're going to say, oh, you only have to wait 1 month to get the Omicron specific one, or they'll say, we haven't made enough because there's a whole manufacturing problem. And so it may not be available to you for a few months. And so maybe it would be better for you to get it around Thanksgiving as an additional dose. So if you have not had a third dose, I would strongly recommend getting it now because your risk is high. And I think we will have to see what happens with that additional one. If I was going to stay home and not be exposed, and I don't have school age children who are going to expose me, and I work in an office and I'm, you know, pretty well able to do that, then I think it's a little bit more of a coin flip if I'm getting my additional booster, but I still think that getting boosted is probably better than waiting. And I think Dr. Wellington agrees.
Absolutely. We get that question all the time. And the answer is, well, so far I have not answered wait. It's always go now and get it yesterday.
Perfect. I'd like to go ahead and thank our presenters for today's presentation. We will provide a copy of the slides on our website and then also a copy of the recording. So if you have any questions, please feel free to reach out to us via our website. Thank you, everyone. Thank you, Dr. Wellington, Dr. Sato, and Dr. Broadhurst.
I will email you those links.
Perfect. Thank you very much.